Hello, good morning. My name is Dr. Farhan. So today I will talk about the jumper's knee, or in medical term we call as a patella tendinopathy. So jumper's knee is a painful condition. It was occur by cause the small tears in the patella tendon itself. The mechanism because of the repetitive constant repetition of the mechanical stress activities, such as people who doing activities such as jumping, running, acceleration or deceleration moving, and also the cutting movement. So the pain or the trauma will occur when the damage time is more than recovery time. The jumper's knee location is commonly at the inferior tip of the patella pole. So where that side is where the patella tendon was inserted. So the other side, but less frequently common occur, is at the quadricep tendons, which is inserted at the suprapatellar portion of the suprapatellar region, and then and also the where patella tendon insert at the tibial tuberosity. So what is the factors can cause the jumper's knee? We can divide into two factors, which is the first one is intrinsic and the second one is extrinsic. So from the intrinsic side is caused by the patient biology or anatomical from the patient self, such as the laxity of the ligament, and then what else? The tightness of the quadricep and also the hamstring itself. Other than that is excessive Q angle of the knee, and then other than that it can be caused by the abnormal patella height also, and then either the patient have a previous injury or previous inflammatory process of the knee, and also the excessive force generation of the knee. While the extrinsic factor is suddenly change of the frequency and also suddenly change of the intensity of the training itself, the changes of the performance level, and then changing the surface of the training ground, such as move from the soft to the hard surface. So normally patient will come complain with the pain at the patella tendon, which is from the inferior part of the patella. It can also be associated with the swelling, and then if it wasn't, if patient moving, climbing upstairs, or prolonged sitting, and also prolonged walking. Okay, so the mechanism itself, some literature said it was caused by the inflammatory process, but that one is all talk of the mechanism. The latest one, they said, is caused by the repetitive mechanical stress of the patella tendon itself, which is and they will cause the small tear of the tendon. So what is the physical examination we can perform is sometimes we can get the swelling from the inferior tip of the patella itself, and then when we palpate, patient will complain the pain. Other than that, we can perform also the some what we call it is test, a Bassett sign. Bassett sign is a passive extension and flexion sign, whereas the patient was lying down, and then examiner palpate at the inferior pole of the patella. It is positive when the examiner flex the knee into the 30 degrees, then the pain will markedly reduction of the pain lah. So other than that, the standing active quadricep signs, which is we position patient in the standing position, and then pain will reduce when the knee was flexed to the 30 degrees. Okay. What is the imaging or supportive diagnosis we can do for the patient is the most easy and the low cost saving is ultrasound. For the ultrasound is a faster we can do, and then it's a mobile we can do in the clinic, and then it's a saving cost lah. What we can get from the three pathological changes in the jumper's knee using the ultrasound is the first stage, if a patient came with the acute within 1 or 2 weeks of the trauma, we can see the edema along the tendon fibers itself, and also the tissue swollen and also thickening. But from the ultrasound, we can see that there is a homogeneous changes. That is the first stage. For the second stage is we call a stage with irreversible anatomical sign, which is the heterogeneous appearance with hypoaquate and hyperaquate image without the edema. But the tendinous envelope is well defined. So the third one, the tendinous envelope is irregular and thickened, and then the fiber is appear as a heterogeneous. Okay, so other than that, we can perform also for the X-ray, either AP and lateral, and also the skyline view to exclude the bony fracture. Other than that, we can also perform the MRI lah. So what is the treatment? Treatment of the jumper's knee. We can divide to non-surgical and surgical treatment. For the non-surgical treatment, as usual, we manage the pain, also manage the swelling, ask the patient to rest, but not to immobilize the joint. Because when we ask the patient to immobilize the muscle, especially for the quadricep and also the hamstring will become atrophy. So the ice also can be act as an analgesic and also can reduce the swelling very fast. Other than that, we can ask the coach or the physiotherapy or the patient to modify the activities, do the hamstring or quadricep stretching and strengthening, and then change the training to the eccentric principle, and then or other than that, we can also try for the dry needling, plasma rich PRP, and then PRP therapy, and also the extracorporeal shock therapy wave. But remember, for the jumper's knee, we didn't do for the corticosteroid injection because it can damage the tendon fiber itself. So the second one is surgical treatment. Surgical treatment is indicated for the popliteal tendon tears, and then other than that, if a conservative treatment is failed, so we can try for the surgical treatment. So for the prevention of the jumper's knee itself, currently is insufficient. There is insufficient evidence for the preventive intervention specific for the patellar tendinopathy. But some of proposed preventive measure ask for the increase the proprioception training, and then change the eccentric training, do the more focus on the stretching, also the strengthening part, and then sometimes we can also try for the bracing and also taping. Okay, so other than that, reduce the training duration and also frequency. Okay, I think that's all for today. Right, thank you.